Good morning. Thank you for the invitation. And being the Pope with this final name, Cohen, it's a difficult task. But I will do I'll see what I can do. This presentation has to do with a technique that it's not. My talk is going to be about these issues. What are we talking about? Well, this is not a new technique. This is a technique that is already used in radiologists, So radiologists are well known with this technique. And they use it mainly in the breast feed, in the urological field, and also in hepatology. And they have very good correlation with the clinic. And they also use this technique in order to do biopsy, guided biopsy, mainly in the prostate. So it is not a new technique. This technique incorporates two different image modalities. So here we use ultrasound, of course, and we use MRI, because we don't use CT in the fetal field. But you can also use CT images. And of course, it complements information and quality of US images. There have been recent advances that there are some reports of the use of fusion in the obstetrics field, but they were things and persons gave up this technique. And there have been recent advances, technological advances, that put this technique again on the field. And we're going to talk about it. Briefly, some technical issues. And the technical issues have to do with the system and probe preparation. You have there, on the right side of the screen, you have the transmitter. This is a very important part of the issue. And the transmitter is coupled to the ultrasound machine. So you have to set the transmitter position. Then you have to mount a magnetic sensor you have there on the left side of the screen. And the magnetic sensor is clamped to the probe so that it is completely parallel to the probe. The very important part of this thing is to put the transmitter in the correct position so that the quality of the images will be better. And there are these are the fields, these are the distance more or less that you should respect when you're trying to do fusion. It is very important to acknowledge also that this transmitter has some problems with pacemakers, for instance, and some with magnetic fields. So you have to be aware of this. Of course, the lady first goes and does an MRI with the fetus, and then we install the data set from which comes in a CD in the ultrasound machine. And then the most difficult part of it is the back office work, let's say, because we have to select the reference data. It means we have to know what are the images, what are the planes that we want to select. And it's not easy. And to load them to the hard disk of the ultrasound. This would be very simple. This would be a very easy way to do it if we had to think only in the direction of a reference image. Okay, we have the pregnant women. We know that the pregnant woman is with the head right, with the feet left, and we should scan it by MRI. But here we have a problem. We don't have only one patient, we have two patients, and the fetus is inside the womb. And when the lady is in this position, the fetus can be in one position. And after that, when he comes to the ultrasound room, the fetus can be in a completely different position. So Here, you're not dealing with just one direction of reference image. You can be dealing with several reference image problems. So the fetus is moving, and that's a big problem. Of course, we can rotate a reference image. We have 3 axes, X, Y, Z. And of course, when and we are just in the beginning of the technique. And as normally occurs, when you're just beginning a technique, you have to concentrate in what you're doing, and you have to let other people work with the buttons. And that's what we are doing, and I have the support here of the technicians. And it's not an easy work to start with. So we have to rotate the image to go to the same planes we have in the MRI. And then to set the target point. Okay, so the patient is in the position, the fetus is in position, and now we're going to try to synchronize the images. I have here 2 examples, and on the right side of the screen, you have some dot, a green dot, and you will notice that we are looking, on the other part, we are looking, the image will go again, and we'll go for try to get the same image, the same plane, and then it starts the fusion technique. So we have to have same planes, or try to have same planes. And you will understand easily, that's on the left side. We're going to search for the planes, and then the ultrasound image begins. And when you're scanning to the left, you're scanning to the left of the MRI image, and the right, you're scanning to the right of MRI image, if the synchronization is okay, and if the direction of the rotation is okay. Otherwise, you will completely lose in your ultrasound machine. And you can understand, because of this, why, and we are in the beginning, almost all the planes, almost all the images I have to you, almost all examples, are sagittal views. Because one thing that we have just proposed to the technicians is that we just have one target point. And it would be easier if we had 2 or 3 target points. Because when you have sagittal images, it's much easier to get the corpus callosum, and the corpus callosum here are examples at 27, 30 weeks. The corpus callosum has almost 25, 30 millimeters. So you have the corpus callosum, you can put the target point, and you know that for at least 30 millimeters, you are in the correct point. It would be much easier if you had 2 or 3 target points, because you could select and you could have more synchronized images. So, as we are in the beginning, most of the examples I have bring to you are sagittal views. And you can see here, now I have you can see here, and you can see here on the ultrasound, you can see here the same images. You can see clearly the bone, the sphenoidal bone. You can see the corpus callosum. You can see the cingulate fissure, yeah. And you can see also the parieto-occipital fissure. And I think it's going to appear there, here. You have the hippocampal fissure also. So, an image here to show mainly the corpus callosum, but in which you can also see the sella turcica here. So, now to the brainstem, going to the brainstem, again, in the sagittal view, you can say the pons hyperechoic and the rest of the brainstem hypoechoic, as it should appear. Again, the cingulate fissure. Here, also the parieto-occipital fissure. Well, the pericallosal artery here demonstrated also. pericallosal artery in a SMI mode. It's a new, different approach to Doppler images, Doppler exams, and at the end of my presentation, you will understand why I have brought this. The vermix. Here you can see clearly the fastigium, the primary fissure, the fourth ventricle there. So external surface, you can look at the Sylvian fissure. And the anterior complex, as it has been described by the group of Vinales. You have there Flavia at the bottom of the room, so you can also look at the anterior complex. Of course, the gyrus callosum, the interhemispheric fissure, the corpus callosum. You can also see almost the posterior complex there, with the periecto-occipital fissures. So, what are our main limitations? Our main limitations are fetal movements, of course. And as we have fetal movements, of course, we need to permanent synchronize images. So we have our images, the data we record are not long videos, because when the baby moves, of course, we have to stop the image, because otherwise the images will get distorted. So we need permanently to synchronize the exam. And in the beginning, it's a little bit messy. The image quality, of course, will have distortions. You have to have expertise in neurosonography. You have to learn with the neuroradiologists. And the advantages of fusion technique: you don't need an MRI at your hospital, so the patient can do the MRI and can come to your hospital if you don't have an MRI. And mainly it brings, let's call the neuro team into the ultrasound room, and it's not easy, mainly when you have to counsel patients. It's very reassuring that the neuro team is there when you're talking about fetal central nervous system problems. And for me, the most important part of this, it is, and for me it is important because I teach how to do neurosonography. It's a good learning tool for neurosonography. The future. When we were scanning, we get several images, and one of the images was this one. Okay, you can see very well the hippocampal fissure here. But what I wanted to show is this, the placenta. You can see it clearly, you can see it very well, and with one of the ideas that occurred to me when I was preparing this session was that this could be also a very good way to map a placenta. If you're talking about, for instance, moral chorionicity, because if you know where the two cord insertions are, and you know when, before you do a laser, you have to put it in your mind before entering the uterine cavity, you have to put on your mind where is the superior cord, where is the cord, where is another cord, where is the recipient, where is the donor. It would be a very nice approach to try to map the placenta, to know exactly where the equator of the placenta is. And it would be important when we perform laser techniques in order to first know correctly the entrance point, and also to get immediately to the equator of the placenta so that you can reduce the time of your intervention. I must thank you for your attention, and I'll be here for any questions you have.